From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Web and Social Media Editor, Dr. Amalia Cochran, and today I am speaking with Dr. Pauliina Homsy and Dr. Patrik Lassus at the Department of Plastic Surgery at Helsinki University Hospital at the University of Helsinki in Finland, regarding the survival of the first 50 face transplants worldwide. Dr. Homsy and Dr. Lassus, thank you both very much for being with us here today.
Thank you very much.
Yes, thank you for having us.
I was immediately impressed by the potential for complexity in your data collection process because of the fact that you were trying to collect all of the data from everywhere that it's available. In light of recognizing that complexity, what was the biggest challenge for you all in conducting this study?
Starting the study, we were actually quite easily able to identify all the face transplants done to date, either through existing literature or personal communication with colleagues at the established transplant centers. So that was altogether 50 transplants performed in 18 centers and 11 countries. But what was missing was the long-term follow-up data for most of these patients, as it simply hadn't been published.
Yeah, I think one of the big challenges is that not all the cases have been published. So we got to know them from personal communication, and also the long-term follow-up is missing from many cases. So we really wanted to have the comprehensive data from all the 50 face transplants. So the only option was to contact all the centers directly. So we sent them a data sheet, and because there are still only 18 centers that have performed face transplants so far, so it's quite easy, and we personally know almost all of them. So we were able to invite everybody, and they all wanted to be part of the study, and they gave the updated data. So we were able to achieve comprehensive updated data from all the first 50 face transplants done up to date.
That's really amazing that you all were able to develop such a wonderful collaboration for this project.
I think the community is quite small, so it is still quite easy. Maybe after 10 or 20 years, it will not be as easy.
Sometimes there are big advantages to being first. Standardized chronic rejection criteria seem to be a work in progress in the field of face transplant. While I know that this strays a little bit from your manuscript itself, I want to take advantage of your expertise in terms of helping me and the listeners understand what are the limitations in creating standardized criteria for chronic rejection.
Well, I think the biggest challenge is that we don't yet know how chronic rejection is presented in BCAs, in face transplant or hand transplants, because they do differ from solid organ transplants, being different tissues like skin and muscle or mucosa or bone. So there's a lot unknown yet. And then there are not many cases yet with chronic rejection identified. And actually, some of these have been related to alterations in immunosuppression because of malignancy or infection. So the centers had to reduce the immunosuppression, and then the patient started developing humoral rejection and eventually chronic rejection. And clinically, maybe this is presented as like skin thinning and loss of function, maybe even accelerated aging in the face. But we still don't know yet if this is chronic rejection or something else. And histology, it's getting there. We can see vascular thickening and sclerosis, and eventually, of course, necrosis in the end stage. There is a Banff working group that is working on this, and I'm sure that we will have a defined criteria within a few years. And it is an important question because this is a big long-term problem. In our data, we have 4 out of the 6 lost grafts, allografts, had chronic rejection or graft vasculopathy. So this is a real problem that we are facing.
When you began to examine the data that you all had collected and accumulated from your work with your colleagues, what struck you as the most interesting finding, and why was that the case?
I was impressed purely by how good the long-term survival of the grafts is. So based on the data we have of the first 50 transplants, the overall 5-year survival, it was 85%, and the 10-year survival, 74%. And if we exclude all the patient deaths and focus only on the survival of the transplants themselves, then the survival rates were 96% and 83% respectively for the 5 and 10-year survivals.
Yeah, I think this is much better than what was expected in the beginning when this was started. But also another thing that I was struck by was that we noticed that more than half of the allografts that were lost were from the first 10 patients. So there really has been a clear steep learning curve. And the survival rates from the patients operated after the first 10 phase transplants are much better already. And in fact, over the last 10 years, there has been only one allograft that has been lost, and that was during the phase transplant operation. So I'm expecting to see much better survival rates for the phase transplants in the future. And I think this is due because in the beginning, the true pioneers, they really couldn't be sure what would be the right immunosuppression. So they really jumped in the cold water. And there has been example over immunosuppression leading to malignancies and infections and so forth, creating problems. But I think the whole phase transplant community is very close and there's a lot of collaboration. So I think the knowledge has been shared and there's been a really quick learning curve.
Figure S1 caught my eye because the number of face transplants in any given year has been quite variable over the period of the study. Particularly given your finding that survival of face transplants has improved as more of these transplants have occurred, do you have any thoughts of why we have not seen overall a steady growth in face transplant being performed?
I mean, that's absolutely right. The numbers varied between 1 and 6 per year across the study. And interestingly, most transplants weren't done in the recent years, but over 10 years ago already.
Yeah, that's true. And I've also been a little bit surprised that it hasn't increased faster, but I think that there are many reasons for that. And I think first one is financing the programs. And this has been a problem in the US recently. Whereas in contrast with Europe, half of the European countries, these phase transplants have been financed by public sector. And this is the case in Finland. It's part of our normal healthcare. So we are not based on any grants. So that finance is secured, but this is only in some of the countries. And I think second thing is truly the hype of starting a phase transplant program has gone really bit down since the beginning. And it's a massive amount of work. And there has to be a motor who starts to do it. And maybe hasn't been so many new plastic surgeons or other surgeons getting inspired to start the work. That's one thing. And I think one of the things is also that it requires a really large team, a large hospital with a lot of experience in complex phase surgery, as well as the transplant unit. So the number of potential centers is not that high. But I think there are many reasons, but I'm a little surprised that it hasn't increased faster.
Another limiting factor is that there simply aren't that many patients that would benefit from the face transplant. Because the main principle, of course, is that only patients for whom all the other reconstructive options have been exhausted will be considered for the transplants. For example, here in Finland, we have a population of 5.5 million. And Dr. Lassus and colleagues did perform 2 transplants in 2016 and 18. And since then, there hasn't been a suitable patient that would have progressed to the transplant. And one estimation is that in order for a transplant center to have a constant flux of patients at a rate of around 1 per year, the catchment area would need to be around 25 to 30 million. And considering coordinating a catchment area like that, of course, would come with its own difficulties. And in practice, it would mean around 10 centers in the US, 20 in Europe, and 1 in Scandinavia. And another point would be that although the face transplants are done in many centers with already as the standard of care rather than a part of experimental procedures, there are still countries where they're simply not legal yet.
Yeah, I think the catchment area is a good point because, for example, the population in Finland is so small. We've evaluated in Helsinki for 11 candidates for face transplant, and we estimated that 4 of them would be suitable for face transplant. And of these 4, 2 declined. They didn't want to have a face transplant after we told them all the risks and what commitment it would mean for the patients. And I think that's a wise decision from the patient. And the patient has to have a really bad quality of life in order to justify this kind of treatment, which is quite risky. So there are not that many patients, at least in the countries that are not at war. So that it would never be a big number of patients.
My last question that I have for you all is from a research standpoint, what is the single most important question that next needs to be resolved in the field of face transplantation?
I think clinically, the surgical part has been quite well established in regard to anatomy or vascularity. And the mimic muscle recovery of the patients, for example, is quite good. And as well as sensation, the restoration of the sensation, which can be nearly normal for these patients. So these kind of things have been sort of cleared. Of course, there are long-term problems sort of related to the surgery and functional recovery. But I think the biggest question is the same as with solid organ transplants, is the toxicity of immunosuppression. So I think that would be like the most important thing for this patient. And maybe something we discussed earlier, which is chronic rejections, that we need to have a better diagnosis for that. And of course, prevention, because that will be the big long-term problem for these patients. So I think that's the most important question to be answered.
I agree with Patrik completely in that the immunosuppression is the main issue thus far, because most of the patients nowadays are on the triple therapy of tacrolimus, mycophenolate, and a low-dose steroid in the long-term treatment. And in particular, the tacrolimus is nephrotoxic, so we are seeing reducing renal function, even to the degree of end-stage renal failure in these patients.
Patrik and Pauliina, thank you both so much for spending time today talking with me about your series that looks at the survival of the first 50 face transplants worldwide.
Well, thank you for this opportunity.
Yeah, thank you for having us.
I am Amalia Cochran, Web and Social Media Editor for JAMA Surgery, and I've been speaking with Drs. Pauliina, Homsy, and Patrik Lassus about survival of the first 50 face transplant patients. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.